Hi, my name is Dario Ghostin, and today I'm doing my presentation on chronic obstructive pulmonary disease. Chronic obstructive pulmonary disease, group of common chronic respiratory disorders that are characterized by progressive tissue degeneration and obstruction in the airways of the lungs. Examples: chronic bronchitis, emphysema, and chronic asthma. Causes irreversible and progressive damage, can affect patients' ability to work and complete ADLs. Disorders can overlap. Respiratory failure can occur. Can cause the development of cor pulmonare. WHO states COPD is the third most common death in the world. The patho of chronic bronchitis is chronic bronchitis occurs when there's a lot of changes in the bronchi, usually from exposure to the industrial pollution or smoking. The changes that occur in the bronchi are irreversible. First, inflammation occurs in the bronchial tubes, which result in increased secretions and buildup of mucosis, causing obstruction. Over time, the inflammation and irritation becomes chronic, which leads to the thickening of the bronchial walls and becomes fibrosis, which leads to further obstruction. After this occurs, it becomes very difficult to clear/remove secretions that gather below the obstruction. Due to the obstruction and secretions, oxygen levels start to lower, causing severe dyspnea, which affects the way the patient can complete their ADLs. Some patients develop pulmonary hypertension or cor pulmonale disease. Emphysema. The significant changes the destruction of alveolar walls and septae, eventually leading to overinflated alveolus. Destruction of the alveolar wall leads to loss of surface area for gas exchange, loss of elastic fibers, and decreased support of other structures. Infection and chronic irritation leads to fibrosis and thickening of the bronchial walls that leads to narrow airways, weakened walls, and interferes with passive expiratory airflow. Impaired expiration leads to the following: air trapping and increased residual volume, overinflation of the lungs, barrel chest, and the diaphragm appears flattened on X-ray. Advanced emphysema and significant loss of tissue leads to the tissue in the pleural membrane surrounding large bulbs near the surface of the lungs may rupture, resulting in pneumothorax. Hypercapnia becomes marked as well. Hypoxia becomes the driving force for respiration, and infections are common. As you can see here, these are the differences between emphysema, chronic bronchitis, and asthma. Assessment. 58-year-old patient identifies as male. Patient states he has had a cough for 3 years. Past 2 days, patient complains of shortness of breath and worsening cough. Patient states he is coughing up greenish stuff. Patient stated he can't walk up the stairs at home without stopping to rest. Patient complains of not finishing a sentence without coughing. Patient has a history of 1 pack of cigarettes a day for the last 25 years. Vital signs include BP 146/92, respirations 32, pulse 107, temperature 38.9 Celsius, and SpO2 85%. The nurse assesses the patient and crackles were noted bilaterally to the bases upon auscultation. The nurse applies oxygen 2 liters via nasal prongs. 5 minutes later, the nurse repeats the SpO2. The patient's SpO2 is now 87%, so the nurse increases the oxygen to 4 liters via nasal prongs. 45 minutes later, the nurse reassesses the patient, and the vital signs read as BP 138/78, pulse 96, respiration 16, temperature 38.4 Celsius, SpO2 96% on 4 liters via nasal prong. The patient is sleepy and difficult to rouse. The physician orders the following items. 1. Keep stats between 88 to 92%. 2. Checks X-ray. 3. Labs, ABG, CBC, and BMP. 4. Insert peripheral IV. 5. Albuterol nebulizer. 6. Budesonide formoterol inhaler. 7. Sputum culture. 8. Blood cultures times 2. Results. The arterial blood gases show that the patient is in respiratory acidosis, as well as the patient is at risk for hypoxemia, and that the patient is compensating metabolically. Chest X-ray shows bilateral consolidation in both lower lobes. The doctor ordered Ceftin and Levaquin based on the sputum and blood culture results. Diagnostic testing includes physical exam, chest x-ray, CT scan, multiple pulmonary function tests, sputum culture and sensitivity, ABGs, and labs to test for genetic conditions. Risk factors include modifiable, which is smoking, non-modifiable, which is living in an urban area, environmental exposure, and genetic disorders. Other systems affected by COPD is the cardiovascular system, such as pulmonary hypertension, cold pulmonary, heart disease, and increased workload, and then the nervous system, which is depression, anxiety, cognitive impairment, and confusion. Nursing diagnosis: impaired gas exchange related to altered oxygen supply and alveolar capillary membrane changes as evidence-based by abnormal ABGs and reduced tolerance of activity. For rationale, this is a top priority as the patient currently is in respiratory acidosis, appears sleepy, and is difficult to rouse. Also, the patient's respiratory effectiveness is compromised and has increased carbon dioxide in the lungs and blood. The second one is ineffective airway clearance related to infection and retention of thick greenish sputum as evidence-based by crackles noted bilaterally to the bases, bilateral consolidation to the lower lobes, and sputum and blood culture results. For rationale, airway is a top nursing priority. The inability to clear the airway due to infection and secretions can lead to impaired airflow, dyspnea, and worsening airway resistance. Short-term goal: the patient will maintain an SpO2 level of 88% to 92% within 1 hour of the latest vital sign assessment. Rationale: there's a fine line between ideal and excessive oxygen therapy. Supplemental oxygen should be titrated to improve the client's hypoxemia within a target of 88 to 92%. The long-term goal: the patient will be free of infection within 1 month of starting the prescribed medication, Ceftin and Levaquin. Rationale: antibiotics help eradicate the bacterial infection, which decreases lingering chronic infections. For the first intervention, as per the doctor's orders, the nurse will administer and titrate supplementary oxygen through the appropriate device to keep the patient's SpO2 between 88 to 92%. Rationale: supplemental oxygen can cause toxicity and should be administered at the lowest level that achieves the arterial saturation appropriate for the patient. The second intervention, the nurse will administer prescribed medications such as Ceftin and Levaquin to treat bacterial infections. Rationale: pharmacological therapy is used to reduce symptoms, treat infection, and improve health strategies. Health teaching: the nurse will teach the patient the importance of not smoking. The patient can also be referred to a smoking cessation program. The nurse will educate the patient on the importance of taking antibiotics as prescribed and finishing antibiotics until the prescription runs out. Teaching strategies: the nurse can build rapport with the patient and create a strong nurse-client therapeutic relationship with the patient and family. While building rapport, the nurse can create an open, safe space for the patient and the family to learn. The nurse can also engage in conversation about the patient's willingness to cease smoking. The health teachings can be completed in many different ways, such as one-on-one sessions, group sessions, and teach-back methods. Evaluation: after 1 hour of administration, the titration of supplementary oxygen, the patient's SpO2 was 89%. The nurse placed the pulse oximetry on the patient's finger for continuous SpO2 readings. The patient's oxygen administration was titrated down from 4 liters to 2.5 liters via nasal prongs. At 5, 15, 30, and 60 minutes, the patient's oxygenation was reassessed. At the 30 and 60-minute assessment, the patient's SpO2 read 89%, which concluded that the patient met his short-term goal. If the goal was unmet, the nurse would continue to titrate the patient's oxygen, administer rescue inhalers, and use different devices to administer the patient's oxygen. After 30 days, the patient's blood and sputum cultures were negative for infection. During the patient's hospitalization, the nurse administered the prescribed antibiotics as per the doctor's orders. At home, the patient continued the antibiotics until the entire prescription was administered. 30 days after starting the antibiotics, the patient completed blood and sputum cultures. Both cultures were negative for infection. If the goal was not met, the doctor could order another round of antibiotics, order different antibiotics, or order another blood and sputum culture after the other antibiotics were administered. Here are my references, and I would like to thank you for viewing my presentation.